Welcome to Quality. This is your host, Arjun Venkatesh, where we're exploring quality in emergency care. Today's episode is the next in our series around venous thromboembolism as part of the Emergency Quality Network VTE initiative. I'm joined by the co-lead of that project, Dr. John Sather, and our special guest today is Dr. Kelly Bookman, who is Senior Medical Director for the Emergency Department Service Line at UC Health, multiple sites all across Colorado. And she's really sort of taken all the things we talk about in our series that are about guidelines and clinical evidence and research and got into practice and figured out how you crack this nut and make improvements in care for patients with VTE. So Kelly, welcome to the show.
Thank you for having me.
I got to kick it off by sort of just asking you to sort of tell us about your success. You know, I think there's a lot of these on these quality episodes or a lot of the quality improvement literature where we spend a lot of time talking about the gaps, right? A lot of papers about, oh, there's, overutilization of CAT scans for PE, or there's overadmission, or we don't have the medications right. So we spend a lot of time, sometimes in the quality world, talking about the problems, but less time than we should talking about real solutions. Tell us about what you all did there in Colorado.
Well, so it's been an interesting journey. We've done a couple of things iteratively to get to where we are now. Going back to 2017, we realized that we wanted to be super engaged in clinical decision support and how embedding things right within the electronic health record at the point of care or the time of care could help drive standardization of care and best practice. So we've had a few bumps along the way, but I'm happy to share with you what we've learned through the bumps. But our biggest success, I think, is really in the space of putting clinical decision support right at the time of decision-making for providers to use.
I got to say it. Whenever I hear the word clinical decision support, I am sure that many of our listeners have this like immediate visceral reaction. They turn a little into like one of that red angry emoji. It feels like a BPA. It feels like you're getting interrupted. It feels like a nuisance, but you're smiling. They can't see that. You're smiling about this one. How is this clinical decision support different?
Yeah, so it's a great question. Well, I'll tell you the first clinical decision support, which we did and published at one of our academic sites, was an interruptive alert. And it was one of the first forays into us trying to figure out whether or not you could even do clinical decision support. And if you did, would it be effective? So we did start with some very, very sophisticated interruptive alerts, aka BPAs, for those of us who have Epic. But they were sophisticated and they only fired when they should. And while people didn't love them, they did have their faces turn into those red emojis. It worked. And so that was our first thought of, if you embed clinical decision support, does it even work? And it did work to actually drive standardization of care and make people, if they didn't need anything, don't order anything. If you need one of the tools like a Perk or a Wells, or EARS or whatever it is you're using, allows you to use that right within your workflow. So we built it that way. And the feedback was, this works, thank you very much. Can you stop it from being interruptive, to your point? So our real success story is that we leveraged a pathway-based embedded platform, which is not interruptive. So you have to remember to go out to the pathway, but the pathway is such a value add that people go there on their own without having to tell them to do that, because once you get there, you've got embedded clinical calculators. So all of the stuff is there. So right within that patient's chart, right within there, you can start getting to any calculators you need to use. And then it writes into the note for you. And then you just walk through, and if you find the right diagnosis, then you get the treatment. And right from within the pathway, you can click buttons and it places the orders in Epic for you. So it's not a static PDF that you look up on a wall and you have to go through the algorithm. It's actually right embedded within your workflow. And so it's naturally value add and super intuitive.
That's interesting, Kelly. Tell me a little bit more about what's kind of in that pathway and kind of how you rolled out the project and how you measured success. And specifically, when I think about VTE, we kind of have three elements: the diagnostic process, the treatment process, and then the often not discussed sort of disposition follow-up process. Does your pathway include guidance for all three of those? And tell us a little bit more about that.
Yeah, it sure does. Actually, we started with so we have two pathways that are diagnosis pathways. One is a DVT diagnosis pathway, and then we have a PE diagnosis pathway. And then those are linked out to a DVT treatment pathway and a PE treatment pathway. Within those treatment pathways, we have both how do you treat the super, super sick, and, how do you get ICU and echocardiograms and all of those things. And then most of the time, obviously, you end up in the discharge pathway. And how do you do that? All the way down to having links out to coupons for people who may or may not be able to afford their DOAC or whatever the appropriate treatment modality is. Backing up to the diagnosis pathways, we have the clinical calculators in them, and then we describe trying to drive people to the lowest resource utilization to make a diagnosis, and including pretest probabilities. All of that's in there in one compact algorithm that providers can just easily click through, and it's right there in the electronic health record.
Do you have a sense of compliance or use of the pathway? Have you examined that?
Yes, so I actually pulled that up prior to talking because I had a sneaky suspicion you might be interested in that. So we have our DVT treatment pathway, for example, is live across all of our EDs, across all of our hospitals, and has been live since August of last year. And we've had 1,100 opens to date. And then in the last month, we've had 114 opens. So it's definitely one of our highest utilized pathways. And I think it just shows that it's a value add, because you can do all of the work right there, and you can bring things right into your note. So it helps you with documentation. Whether you're going to do something or not, it helps you with your documentation, and it helps you with your orders as well as your decision making.
Tell me, when you are describing these pathways, one of the things when we've been talking to EDs that are trying to get new QI projects in the VTE space going, especially if it's around sort of discharging low risk PE, we'll say, there's a lot of, before you've started the project in the first place, perceived resistance, meaning that people are afraid, well, that their docs are going to be resistant to doing this because they're so used to having admitted patients always, and that's going to be, no matter how many fancy whistles you put in the EHR and what you give them, that resistance will keep it from succeeding. Or you even hear the other side, which is, again, a perceived one, but that patients are going to be resistant, right? That the PE is a serious diagnosis, anticoagulation is a big deal, that they're not going to be okay with going home. What's your experience been around these two? Like, are these well-born? Do they really happen? If they do, how do you manage them?
Yeah, so we have right now 14 hospitals across our system, one big academic center, and then everything ranging from small ski town type hospital all the way up to very large community facilities that see 100,000 patients per year, and everything in between, rural, semi-urban. And so it varies depending on where you are. So the academic center, they accepted sending home patients even back when we had to teach them how to do sub-Q injections. And we had videos to do that, and we taught people how to do that. And at the academic center, that was well accepted, easily accepted, because they're sort of used to changing the way that they practice as things move. And then as you go out further into communities and people who've been further out from their training, there was definitely resistance, especially when it was something harder to do, as going to oral anticoagulation has become more the standard of care. That resistance has gone down particularly for VTE treatment at home. And at this point, we don't see as much resistance even in the community now that we've got the ability to send people home like that. But it is true and it's real. And the way that we had to do it is we do a lot of boots on the ground work when we roll out any pathway. We have a lot of pathways, not just this one, but we do a lot of work for each pathway to get the local leaders to understand the why and the literature and how we're doing it. And we have them go right to the frontline folks and answer questions and try to get them to change their practice.
Was there involvement with the non-EM providers that these patients would follow up with? Did you bring them in to develop the pathway? Have you worked with them to sort of receive these patients after ED discharge, to streamline that? Is that a component of this?
Yeah, absolutely. So for all of our types of pathways, we work cross-discipline and or cross ambulatory, inpatient, and ED, right? Because it's all a continuum. And if you're really going to send somebody home, then you need to be comfortable as an ED doc that they're going to get the follow-up you need, especially if you're doing something like starting them on anticoagulation. So we very, very specifically worked with our primary care physicians to make sure that we had good follow-up access. And in some of our bigger facilities, we have anti-coag clinics and things when you had to check if or when you had to check and follow up on things. So we worked very, very closely with our primary care ambulatory providers. And then similarly, we worked very closely with hospitalists who we would admit to if we were admitting, and or our IR team if we would actually be doing an intervention, or our ICU team to create things like, pulmonary embolism, rapid response teams and that sort of stuff. So we definitely pull them in, and we don't do this in a silo where this is what the ED docs think we should be doing. We get everybody's expertise.
It's interesting. One of the things that sort of comes up, and I'm wondering sort of how people feel about this in your shop, is that with all the new medications, particularly as DOACs got rolled out, there was a lot of concerns about cost and price and, can patients afford this? But then there's all these complications as well around Coumadin. And so in your pathways, have you been able to sort of simplify this so that your clinicians can feel like they're making the best choice and that they don't have to worry about that? Like, are you getting it, like sort of the myths that are out there that keep people from doing the right thing?
We write these pathways so that, quote, even a medical student or an intern, even an off-service intern, can follow them and understand them. So we don't write them for the very top echelon. We make sure that they're written in as layperson as possible. So we do that. So nobody knows how much one of the DOACs costs and which you would pick if somebody has this kind of payer or the other kind of payer or no payer. So we specifically lay that out for folks to say, in the case of DOACs, choose this one if your patient meets this criteria, choose this one if your patient makes this criteria, and choose this one if they meet another criteria. And then we help them to mark through. So if Coumadin happens to be the one you have to choose, we set it up so that you can get your PT follow-ups, and we, give good instructions around that. And I think, like I said earlier, we embedded coupons. So, right, like some of the DOAC companies had coupons specifically that would help people to be able to afford them. So we built that stuff in as well to really help to make people feel comfortable with the decisions that they're making and that they're not potentially burdening their patients with a medication that they just simply couldn't afford.
A lot of these pathways get developed, and I think there's a novelty to them. And I think with the right sort of presentation, sounds like you've done a really nice job. You get people excited, and if you're lucky enough, they comply and they use it. How do you prevent fall off?
So what I've said is, so we follow it. So obviously I was able to pick I have the number. So I know every month how many times each pathway is being opened or being utilized, or orders are being utilized from it. And I can see if there's a fall off. So if there's a tremendous fall off, then I try to gather into why. And I can even look down to the individual level to see, did it fall off at a hospital? Particularly, did it fall off at a freestanding? Did it fall off in a region? Or is there a particular provider or provider set? So we can give feedback directly or look for trends there. But for us in specific, sometimes what happens is you have a pathway and everybody then learns that pathway. And so they don't necessarily need to go out to the pathway to do the right thing. So depending on what's in the pathway, sometimes you'll see fall off, and it's not because they're not following it. It's because they've learned it. And unless you change it, they've learned it and they figured out other ways to be equally as efficient in using it. So we use pathway openings as a proxy, but we actually use outcomes as the way that we determine whether or not we've been successful. So if we continue to have, insert KPI here, an appropriate number of patients discharged once they've been diagnosed with VTE, or if we don't see inappropriate or avoidable admissions that could have been treated as an outpatient, those are the things that we look at, and we use the pathway as a tool to help drive that standardization of care, if that makes sense.
Can you tell me a little bit more about how you're monitoring that, or do you actually keep a database, kind of a quality database of the low risk VTE that get discharged appropriately versus get admitted, and vice versa, the missed PERT opportunities or high risk PEs that got admitted to a floor and then decompensated? Do you have a database and a way to screen and provide feedback?
So we use, it's not quite as slick as I would like it to be in terms of having a dashboard or something like that that tells us that. But we do a lot of evaluation of unnecessary or avoidable admissions. And we do that by screening, patients who go home within less than 24 hours or within less than 36 hours. And then we screen and look for trends. And if we see trends of VTE patients being a cohort, not just a one-off, then we review that and then we give individual feedback. And we do that for a lot of our avoidable admissions or our short stay admissions. We even look a little further out because we know once you admit somebody to the floor, they often stay longer than they might have. So we try to look at 24 hours, 27 hours, 36 hours just to see. But that's how we do it. I don't have a dashboard though. I'd love a dashboard.
I think it's a good point though, because I worry about sometimes the power of, like, inertia is really powerful. And so I could imagine that there's a patient who would be totally suitable for, I may even have a preference for outpatient therapy, but once you trigger the cascade of an admission, doesn't necessarily mean that they leave in 24 or 36 hours, right? It can easily be a 2-3 day hospital stay because there's sort of this confounding by indication. People get admitted to the hospital, you assume they're sicker, and so they sort of get reassessed as higher severity, and then you start doing more tests, more diagnostics, more consults. And so it's important, I think, in some ways that we recognize that it's not just the power to sort of admit or discharge a patient we often have in emergency medicine, but it's also the power of, which cascade of care do you then subsequently sort of put a patient in.
Yeah, and I completely agree with you, Arjun. One of the things that we do is we've empowered our hospitalist team all the way down to the resident level. If they feel that they have a patient that they recognize, not just VTE patients, but anybody who might be an avoidable admission, we have a process whereby they can easily send this case for review, and then we have a small group of hospitalists as well as ED docs who review it, right? Because you're going to have differences of opinion, and then if they do, then we look to see if there's an opportunity to operationalize that cohort of patients to prevent avoidable admissions. So we do look at that and try to have a process to get those, because you're absolutely right. They will keep them in, and then they'll do further workup, all of which could have been done as an outpatient, assuming there's access.
All right. So Kelly, I have to bring up maybe a little bit off the theme, although maybe we can tie it in, but I did a little bit of research prior to this podcast and learned a little bit about your dad. So tell me about that story. I think that's pretty fascinating.
Thank you for asking. My father is one of the pioneer first generation emergency medicine residency trained board certified docs. So in the mid 70s, he went through one of the first residencies and graduated. And then for better, for worse, I followed in his footsteps and was interested in emergency medicine, even though he recommended that I look for everything else, but it just suited me to be in emergency medicine. So I also likewise am residency trained, board certified in emergency medicine. And we believe that I'm the first second generation residency trained board certified emergency medicine physician in the country. And it's been fun to have him here, but it did make me go get trained elsewhere. So I do have a few shifts as a medical student where he was the ED attending, and that was uncomfortable. So I went away and trained and came back, but it's been a lot of fun helping to build emergency medicine in Colorado, which is where he practiced, to bring it from where it was in the 70s to where it is now.
Well, it's interesting that the two careers. So your dad sort of came in and really established a role for emergency medicine, and as I understand it, in a fairly rural community in Colorado, and kind of built that system up. And here we are now, a fairly well-established specialty, and now it's you're developing sort of the next phase, which is developing how we are situated within the house of medicine. And I think we're coming to learn that we've got a great role to play in terms of resource utilization, patient safety, patient quality, kind of the things we talked about. So you guys, the two of you combined, have had quite a career.
It's been quite a journey, and it's been a lot of fun. And I agree that just from the stages where he started in emergency medicine, where nobody even knew what we were doing, and we were fighting to even be allowed to intubate patients, to now where we are holding very important roles in the continuum of care, and we really are the fulcrum between inpatient and outpatient decision making. We probably make the most important decision made, or at least one of them, as to whether somebody goes home or somebody comes into the hospital. At the very least, it's one of the most financially impactful decisions that's made, and we make it multiple times every day.
Well, it's an honor to have you, and I say it's not just a huge responsibility, as you said, to be at that fulcrum, but it sounds like you guys are doing a wonderful job at succeeding, and really taking a lot of these sort of tried and true quality improvement principles, turning them into practice, generating better care for patients. And I think that's what we're all in this for in the first place. And sharing your success story today with the broader quality network has been great, because I think people need to hear these kinds of success stories to make sort of the art of the possible happen in their own shop. So thank you, Kelly. Hope to have you back on a future episode.
All right. I appreciate the invite and had fun.
Thanks.
Kelly, thanks.
Thank you.